This is a case of femoral fracture and ankylosing spondylitis. In this tutorial video, I will go through the vignette provided to you in the case module. I'll go through an approach to pelvic and knee radiographs. I will apply this approach to the images that were provided to you, and then we will go through the post-module quiz questions together. So a 65-year-old male presented to the emergency department after being thrown from his quad bike when he drove into the ditch. He was in severe pain and was brought to the hospital by friends. On physical examination, he had a visible mass in his thigh and was in severe pain. Laboratory investigations at the time of assessment were pending. This is an example of some of the radiographic images provided to you in the patient's imaging file. And we'll talk more about our finding here, but we can appreciate that there is an obliquely oriented fracture through the proximal femur. And when assessing femur radiographs, it can be helpful to provide an approach to both pelvis and knee radiographs in order to provide a complete assessment. I am going through the ABC's approach to radiographic interpretation. I find this mnemonic is helpful for people who are new to image interpretation to help them remember the different structures they want to assess. It doesn't matter how you perform your search pattern as long as you're systematic and consistent once you find an approach that you like. That way it can reduce the chances of missing a more subtle pathology. So A stands for alignment, and there are different rings that you can trace within the pelvis. So you can trace the pelvic ring here, outlined in yellow, and the obturator rings outlined in red. Additionally, you can sometimes see the sacroforamina. It's perhaps less visible in this patient because their sacrum is partially obscured by bowel gas. Additionally, there are multiple lines that you can trace in your mind's eye that we'll go through in the next slide. So we have the iliopectineal, the ilioischial, Shenton's line, and evaluation of these sacral struts, just to name a few. Additionally, you want to trace the cortex of all the osseous structures that you see to look for any cortical discontinuity that might suggest fracture. Additionally, it's possible that you could find a skeletal mass. For cartilage, you can assess the SI joints up here, look for any abnormal widening or increased sclerosis. In pathologies like ankylosing spondylitis, for example, which we'll talk about later, you can see fusion of the SI joints bilaterally. Additionally, evaluate the symphysis pubis to look for any abnormal widening or diastasis, because that can be indicative of an unstable pelvis fracture. And last but not least, you want to assess the acetabular joints bilaterally, which is what articulates with the femoral heads. And last, soft tissues / everything else. You can look for different fat stripes, where we'll talk about in a little bit, where you can have displacement of the fat stripes and what that means. You can look for any soft tissue masses, abnormal soft tissue edema, or calcifications. So this is an example of the different lines that you can trace with your mind's eye. So here we have the iliopectineal line, which serves to evaluate the anterior acetabular column. The acetabulum is composed of anterior and posterior columns. So again, disruption of this iliopectineal line can be a sign of an anterior column fracture of the acetabulum, a fracture of the superior pubic ramus, or a fracture of the anterior pelvic arch. Here in orange we have the ilioischial line, which disruption of this line can suggest a fracture of the posterior column of the acetabulum. Here we have in blue the roof and medial wall of the acetabulum. In green, we have the anterior wall of the acetabulum, and in red, this line represents the posterior wall of the acetabulum. Lastly, we have Shenton's line, which we can trace over here in yellow, and disruption of that line can be indicative of a fracture of the neck of the femur. Here we have different fat pads that we can see within the pelvis. Over here we have the iliopsoas fat pad, so any abnormal bulging of this stripe can be indicative of a hip joint effusion. Down here we have the gluteal fat pad, in which bulging may also indicate a hip joint effusion. And over here we have the obturator fat pad, so displacement or bulging of this fat pad can actually indicate a pelvic sidewall hematoma secondary to a fracture. So if you could imagine if there was a pelvic fracture and we have a hematoma forming against the pelvic sidewall here, that density is going to push this fat pad over to the side and cause it to bulge. Next we have an approach to knee radiograph. So again we have our ABCs. A stands for alignment, and you want to make sure that there's appropriate tibiofemoral alignment. So if we draw a line from the lateral femoral condyle down here, it should be in proper alignment with the lateral tibial plateau, and the same thing over here with the medial condyle and the medial tibial plateau. Next, you want to assess the position of the patella. Whether a patella is sitting too high or too low has different clinical implications that we'll go through later. And there are actually measurements that you can take to see how high or low the patella is sitting. And we'll discuss that once again over the next couple of slides. Next, as always, you want to trace the cortex of the bones that you see, and just make sure to pay extra attention to the tibial plateaus and the intercondylar eminence here. On the lateral radiograph, this is where you can see the plateaus and the intercondylar eminence. So oftentimes fractures of this region can be quite subtle, so just paying a little bit of extra careful attention to these regions can help you to avoid missing a subtle pathology. Next, when you think of the cartilage and ligaments, you can think of all of the attachment points around the knee for the different ligamentous structures, and that is why knowing your anatomy is so essential in radiology and in radiograph interpretation. So if you know the normal attachment points of structures like the medial collateral ligament, the lateral collateral ligament, the anterior cruciate ligament, and the posterior cruciate ligament, can help guide your eye towards subtle avulsion fractures that may otherwise be missed. Lastly, soft tissues / everything else. Abnormal soft tissue edema can be indicative of an occult fracture or a ligamentous or cartilaginous injury. So you'd want to assess the prepatellar fat pad, the anterior suprapatellar fat pad, the prefemoral fat pad. You could look for any intra-articular loose bodies, and once again, any soft tissue masses or calcification or areas of abnormal edema. Over here we have the anterior suprapatellar fat pad, and here we have the prefemoral fat pad. So when fluid collects with a knee joint effusion, it's going to collect up here and separate these two fat pads, as we can see over here in red. So we have a widening of the distance between the anterior suprapatellar fat pad and the prefemoral, so pre-femur. And in between this widened space we have a soft tissue density here. So this can lead us to believe that there is a knee joint effusion and would prompt us to more carefully scrutinize the area in question in case there's an occult fracture. I also think it's important to just quickly go through how to identify the medial versus the lateral femoral condyles. One way to define what the medial condyle is to find the adductor tubercle over here. And additionally, the medial femoral condyle will have a convex distal articular surface and will also be larger than the lateral femoral condyle. And this is because of the divergent pathway of an X-ray beam, and how the technologist positions the patient for the radiograph itself. Typically for a lateral knee radiograph, the lateral aspect of the knee will be against the imaging detector. So consequently that means that the medial femoral condyle will be farther away. And due to the divergent path of an X-ray beam, this medial condyle will now be magnified, and its distal articular surface will be projected inferiorly. Also, on the lateral femoral condyle, there is a condylopatellar sulcus, also known as the lateral notch, whereas once again, the medial condyle will have a convex distal surface that won't have a notch. Next, talking about the positioning of the patella. So if you perform measurements in these places outlined in yellow and red, it can give you something called the Insall Salvati index, and normal for that is between 0.8 and 1.2. So if we have a Insall Salvati ratio less than 0.8, that's indicative of patella baja, or a low-lying patella, and what that can be indicative of is a quadriceps tendon rupture. Because if you can imagine, if the quadriceps tendon ruptures, you now have this patellar tendon acting unopposed, contracting, and pulling this patella downward, resulting in an abnormally low position. In contrast to that, if you have a Insall Salvati index or ratio greater than 1.2, you have a high-riding patella, or patella alta. And that can be indicative of a patellar tendon rupture. And the similar concept can be applied. So now you have this quadriceps tendon attached to the superior aspect of the patella, contracting and pulling that patella upward unopposed by the ruptured patellar tendon, resulting in a high-riding patella. So if we apply our approach to radiograph interpretation, we can look at the alignment. So again, we can trace the pelvic ring, the two obturator rings, make sure they are smooth and continuous, assess for the sacral foramina to see if they're patent or disrupted. Here we have our sacral struts. We want to make sure that the cortex there is continuous as well. And again, we can draw our lines. So we have our iliopectineal line, our ilioischial line. We have Shenton's line here. And again, we look for disruption of those lines because they can be indicative of different pathologies. Again, you want to trace the cortex of all the osseous structures that you see. You can't only trace the pelvic osseous structures. You also have to look at the visible lumbar spine here and look at their transverse processes as well. When you're assessing the cartilaginous spaces, think of the sacroiliac joints, look for any abnormal widening or increased sclerosis, look at the symphysis pubis for any diastasis or abnormal widening, and assess the acetabula bilaterally. And then finally, in the soft tissues, you look for any abnormal edema, displacement of any of the fat stripes that we talked about earlier. And you can look for abnormal calcifications or masses. In particular to this pelvis, you also have to examine the bowel gas pattern within the visible portion of the abdomen as well, in order to be systematic and complete with your assessment. So what we find after our approach is we have a discontinuity or cortical breach / fracture in the proximal femoral diaphysis or shaft. This looks obliquely oriented, and we can see here that this distal fracture fragment is displaced and no longer associated with this proximal fracture fragment here. So this leads us to question 1. Where is the fracture? As already discussed, it's in the proximal femoral diaphysis. Diaphysis of a long bone stands for shaft, and then as you get towards the end of the long bone, which is the epiphysis, you get this splayed, sort of widened portion, also referred to as the neck of a long bone, and that is called the metaphysis. So when we think back to our radiograph and where that fracture is, we know that B is correct. The second question is, what is the orientation of the fracture? So these are some pictographic examples of how we classify the orientation of a fracture. So for instance, we have transverse, oblique, a butterfly segment, a spiral fracture, a comminuted fracture, as we can see many pieces here. And last we have segmental, where we have a breach in two portions of the femoral diaphysis here, kind of resulting in a free-floating fragment in the middle. So when we compare how we classify fractures in this diagram to what we see radiographically, this is most consistent with an obliquely oriented fracture, or A. Later on in the case, in the imaging file, you also have post-reduction images. So the patient in question underwent open reduction internal fixation, or ORIF. And the question is, what surgical hardware can you see on the post-reduction radiographs, or post-ORIF radiographs? And as the name suggests, we can see that there's this rod running down the medullary cavity that is helping to connect these two pieces of separated bone. And what that's called is an intramedullary rod, so in the medullary canal. And that is the correct answer. I will go through examples in the next slide of what the partial or complete arthroplasties versus a compartmental arthroplasty might look like. So this is an example of a partial or hemiarthroplasty. We can see here that the femoral head and neck have been replaced, but the patient still has their native acetabulum. Whereas if we contrast to this image over here, we can see now that the acetabulum has been replaced, as well as the femoral head and neck articulating with this surgical hardware here. And that is a total hip arthroplasty. And then lastly, we have a unicompartmental arthroplasty, which is self-explanatory in the name. Perhaps with this patient, they were only having issues with degenerative changes and joint space narrowing in the medial compartment, because if we look over here at this lateral compartment, it actually looks quite nice and open. So maybe that is why the patient had opted to go for this unicompartmental arthroplasty shown here in the middle. Finally, the last question. When you're reviewing the patient's imaging file, you find an old radiographic examination of the lumbar spine, and you see this. So if you were to pull up this image, what disorder would these findings be most consistent with? And what you see here is sort of this fine, delicate, ossific fusion along the spine of these kind of disc space areas here. There's no longer a separation between the vertebral bodies. It's kind of all flowing together. And this is thin and fine ossification, also known as development of syndesmophytes. And this is a finding that is pathognomonic for C, ankylosing spondylitis, which is a seronegative spondyloarthropathy. Oftentimes patients are HLA-B27 positive, and like I had mentioned in the previous slide, it involves ankylosis, which is either fibrous, cartilaginous, or osseous fusion across a joint, and you get development of these syndesmophytes, so fine ossification of the annular disc fibers. And typically it starts at the SI joints, and it usually affects both of them in a symmetrical fashion. You can get increased sclerosis at first, or sacroiliitis to the SI joints, and eventually, if the disease progresses enough, you'll get complete fusion. Afterwards, the disease will ascend in a continuous fashion up the spine and can affect the entire spine. And what you're seeing here, this kind of syndesmophyte formation, is often referred to as bamboo spine. Other radiographic signs you can get of ankylosing spondylitis is vertebral body squaring. So you can see an absence of the normal kind of concavity that you can see in the anterior border of a vertebral body. Lastly, on this slide, another sign that you can see more on the AP is called dagger spine. You can get linear ossification along the central spine at the interspinous ligament, and what you'll see is this kind of homogeneous, hyperdense line running down the middle of the spine that can resemble a dagger. Lastly, on the left here is a radiograph demonstrating complete fusion of the SI joint. So if you see that in isolation, it can prompt you to perhaps do further imaging of the lumbar spine. And I show this lateral lumbar radiograph to contrast ankylosing spondylitis from a disorder called diffuse idiopathic skeletal hyperostosis, or DISH. And that's when you get wide, kind of bulky calcification of the spinal soft tissues, including annular fibrosis, the anterior longitudinal ligament, and the paravertebral connective tissues. And if you can appreciate, you have this large anterior bridging osteophytosis. It's thick and kind of irregular, in contrast to what we saw with our patient with ankylosing spondylitis, where you see this sort of fine, delicate ossification. And that concludes our case on femoral fracture and ankylosing spondylitis.